Hello, and welcome to Health on the Line from the NHS Confederation, the organisation that represents members from across the health and care sector in England, Northern Ireland and Wales. Today I'm joined by Sir Charlie Mayfield, former boss of John Lewis. Charlie has led a government-commissioned review, which is recently published, looking at how we can keep Britain working. Charlie popped in for a chat to discuss the policy levers and solutions we need to help people with long-term illnesses or disabilities stay in employment. But before we get into all that, let's discuss the state of integrated care systems. At the Confed, we produce an annual report about the state of ICSs, and, well, what a big year this has been to produce such a report. On the one hand, these are organisations that have been subject to a pretty catastrophic process of cuts and mergers. On the other, they're organisations absolutely critical to the delivery of the 10-year health plan. So how on earth are leaders out there in those systems thinking about things? To discuss this, I'm joined by Sarah Walter, who's the director of our Integrated Care System Network and also a deputy director of the NHS Confederation. Welcome to Health on the Line, Sarah.
Thanks very much for having me, Matthew.
Now, how on earth you summarise what must be an incredibly conflicted state of mind out there, I don't know. But what are your key takeaways from the survey findings?
Yeah, I think it is a mixed bag in terms of the survey findings, I'd say, Matthew. Definitely some areas of positivity which we can focus on, but understandably, given the situation that ICSs and ICBs in particular have faced in 2025, clearly some really significant areas of concern and risk. But also lots of optimism about the future, I think. So just as a bit of a kind of overview of some of the survey and some of the key findings, as you say, this is an annual survey and report that we produce at the NHS Confederation, which reaches out to ICB chairs and chief executives and also ICP chairs to get their kind of view on how ICSs are developing, their response to the kind of changing policy landscape. And then this year, clearly, we've also tested views in response to the 10-year health plan, and we've got responses from 34 of the 42 systems represented within this survey. So it's a reasonable kind of proportion of the overall ICS community. And I think it's fair to say people are confident overall about the opportunity for change. 4 in 5 systems, 4 in 5 ICS leaders are confident that they can fulfill the 4 core purposes that have been set out previously for ICSs. Lots of optimism. So over half are talking about the progress that they're making on the government's 3 shifts. And lots of positivity and enthusiasm, I think, also for the 10-year health plan, in particular, the kind of intention to shift spend into the community, the importance of neighbourhood health. I think people can see the opportunity for change and improvement and are kind of positive about some of the things that the government kind of set out through the 10-year health plan. But it is clearly a very challenging environment to be delivering that. When we talk to ICS leaders about some of the barriers for change, I think we will not be surprised to see that the NHS restructures and in particular the significant cuts to ICB running and programme costs are a massive concern. So 95% of respondents were either very or fairly concerned about the impact of those cuts, and clearly concerned about other areas of the system as well. Social care funding, resources within the NHS are kind of are areas that people highlight within the survey.
Yeah, so I'd kind of summarise that, Sarah, having read the report, as a kind of give us the tools and we will do the job, seems to me to be the way I would kind of capture this, as a kind of steely determination to get on with things. A recognition, actually, that ICBs as strategic commissioners are absolutely critical to the challenge of how it is we combine recovery and reform in the context of limited resources, where difficult decisions have to be made. Now, you and I are optimists at heart, but some people listening to what you've said will kind of go, well, hang on, you're putting a brave face on this. Aren't these organisations just absolutely on their knees? How possible do you think it is, Sarah, for ICBs to get through the kind of morass they're involved in at the moment in terms of restructuring and merger, and actually get on to the opportunities of the 10-year plan and building the capabilities that they need to do commissioning and get commissioning right.
Well, I think those are some of the key asks that come out of the report. So there are some practical, almost kind of hygiene factors that need to be in place. We know that the last few months have been ICSs and ICBs in particular have been impacted by the lack of clarity about the costs of redundancies involved in ICB restructures. Some of the communication and the kind of pace of communication from the centre at times hasn't been what we might have wanted, but there is a really clear commitment that comes through the report to the future role as strategic commissioners, and a real sense of um, possibility and opportunity that if commissioners and if ICBs are properly backed, then they can see a way through for delivering really quite kind of radical transformation to the way that the service is delivered in a way that kind of reflects what's set out within the 10-year health plan. So I think people see that it can be done, and they really are seeking the backing and the opportunity and the support in terms of development of some of those strategic commissioning capabilities to make it so.
Yeah, no, I mean, I'm speaking later this afternoon to Penny Dash, and I've heard Penny say, chair obviously of NHS England, I've heard Penny say that ICB strategic commissioning is absolutely central to making the hard choices that have to be made. And I think from that flow kind of 2 points for you, Sarah, which I'm interested to see how the survey reflects this. The first is that, when it comes to commissioning, this is not our first rodeo. We have tried commissioning before, and we tried it for similar kinds of reasons, that it would lead to more challenge to providers. It would lead to a focus on outcomes, and it hasn't really worked, and it hasn't worked for a variety of reasons, but probably amongst the most is that the commissioners have not had sufficient kind of power, capability, confidence to do that tough stuff, or that the things they've been asked to do don't really align with national policy priorities that are often a bit more kind of short term, a bit more activity focus. So I'm kind of interested in the degree to which you think ICBs understand the history of commissioning and their capability to do this differently. What do they need to do it differently? And then the other question is one of the things that shifted between previous rounds of commissioning and this one is the relationship with local government. Mayors will be on ICBs. They might even be chairing them. Our work with local government gives us the opportunity not just to join up around commissioning and health, public health, social determinants, but also potentially to rest on the legitimacy that local government has when it comes to making difficult choices about priorities.
Yeah. So on your kind of first point, I think, the importance of really backing commissioning and seeing what commissioning can deliver, again, I think comes through really strongly. There was a report published by the Nuffield Trust back in September that was focused around lessons on moving care close to home, kind of international lessons. And that really describes also commissioning as a key enabler for achieving that strategic shift. And if you really do want to be rebalancing care, looking at where resources are going, reducing inequalities, ensuring value, then commissioning can be a hugely effective tool for doing that. But you really need to kind of back it and support that capability building as well. Um, the relationship with local government has always been a core part of the Confed's ICS network and our work with ICS leaders. Within this report, we've kind of tested how people see that relationship developing in the context of strategic authorities and the role of mayors. In the context of the 10-year health plan, talking about integrated care partnerships no longer being a kind of statutory requirement. And I think, clearly there's a huge amount of change happening within local government also at the moment. And we do need to take care that kind of the combination of NHS restructure and local government reform is one where we kind of stay true to the population that we're here to serve. The structures can sometimes get in the way of some of these things, and so really focusing, as I think ICS leaders are committed to doing, to the people that we're here to serve, and the ways in which we can better integrate, make get more bang for our collective buck across different kind of public service providers, and really kind of make a difference, I think, at a local level.
So we nearly run out of time, Sarah. But I want to end up by being first positive and second provocative. That's me. That's my style. On the positive front, the report is full of, and people may again be surprised by this, but examples of good stuff that people are doing, things that they think that they have made progress on. Just give us a feel for what it is that ICB leaders are proud of.
I mean, there's some fantastic examples in the report. We can look at kind of examples within North Central London, in Manchester, where people are, in particular, I think, within that kind of neighbourhood health space, looking at developing those place-based arrangements, developing those kind of neighbourhood arrangements in a way that much better reflects the full breadth of partners that can operate within a system context. So not just looking at within the NHS, but within local government, connecting with voluntary sector partners. So there's a huge amount that can be done there.
And the provocation, I guess, I've got, not for you, but for those in power who may be listening, is that one of the things ICBs have suffered from the very beginning has been an ambivalence at the centre. There have been people at the centre who don't really understand what ICBs are, or they just really don't like commissioners. They're just continuously kind of sceptical. And then those are the kind of people who I suspect are applauding when ICBs aren't really given the support that they need to be able to do their job. So it becomes a self-fulfilling prophecy. These ICBs are no good. We're not going to give them the tools they need. We're not going to give them the autonomy they need. Oh, look, they're not succeeding. That proves our point. I mean, I have actually heard people in the centre be as facile as that. We just can't kind of go on like this. ICBs are absolutely critical to the 10-year plan. What's your kind of final message, Sarah, that comes out of this report and leans forward into where we need to go?
I mean, I think it is that given the backing and I think some of those kind of development support. I know NHS England is currently working on a strategic commissioning development program, which will be welcomed. But given that kind of backing and space, I think ICB leaders have the ambition, have the kind of the sense of what's possible to really make substantial change to the way that services are delivered, and are really behind the ambition set out in the 10-year health plan. So I think if we do want to be radical, and if we do want to achieve actually kind of something quite transformational in terms of how services are delivered, then I would argue that ICBs are in exactly the right place to be able to lead that.
Give them the tools and they will do the job. Sarah, thank you so much for joining us on Health on the Line.
Thanks very much.
Now, returning to the main topic of this episode, I heard from Charlie Mayfield all about his government review and how we can help people stay healthy, supported, and employed. Charlie, welcome to Health on the Line.
Thanks, Matthew. Good morning and nice to be with you.
So, Charlie, I want to kind of go through the report, go through the story. I want to start with the problem. Now, I'm interested in, we all kind of know the kind of headlines here. There are a lot of people who are of working age who aren't in work, and the biggest reason for that often cited is health and care. But I was reading a piece in the FT last week that said actually overall our activity rates aren't that dissimilar from other parts of Europe. So what really is the story here, Charlie? What is the problem?
So I think the problem is that we as a society are seeing a rising incidence of ill health, and that is obviously playing out in the workplace. And we are undoubtedly seeing an increase in the number of people who are leaving the workplace for reasons of ill health, and also occasionally for disability reasons. And that is driving a level of inactivity, which is basically bad for individuals. It's bad for employers, and it's definitely bad for the country. The international comparisons are always a bit tricky and a bit complicated, not least because the people measure these things in different ways. But our figures suggest that if we were to get to the same levels of activity, economic activity that you see in other countries, other sort of advanced economies, you could be looking at something in the region of 1 million to even as many as 2 million more people being in work. So the scale of the gap is significant, and obviously the potential, if we can fix that, is huge.
And I guess the important thing here is also the kind of trend, isn't it? There are, I think, 800,000 more people of working age who are economically inactive for health reasons than there were before COVID. If you carry that line on, even if it kind of dips a bit, but it continues in the same direction, that's what we should really be worried about, isn't it, Charlie?
Absolutely. So, I mean, this is the issue. Is I think, as Lord Darcy said, we're getting older and we're getting sicker sooner, and therefore this is a societal issue that is playing out in the workplace, and at a very fundamental level. If we don't do a better job of supporting people to remain in work, and indeed, of course, what we should be trying to do is prevent them from getting sick in the first place, then that will spill over into a continuation of the trend that we've seen. And of course, with it comes pressure on resources, and the whole system can start breaking down. So you end up with a very serious problem. But what we're saying in the report is that none of that is inevitable. This is a serious but fixable problem.
Yeah. So let's look at the kind of key ideas in the report, which is a splendid piece of work. And I think the thing that is going to strike our members in the Confederation, and I think please us, is that what you're wanting to start off by saying is that when we think about this problem, we've made the mistake of seeing it as being primarily the responsibility of the individual who's suffering a health or care challenge and the NHS. And you want to say, if we continue to rely on the NHS and the individual, we won't get to the heart of this problem. Unpack that idea for me.
Yeah, no, sure, absolutely. And I think, at the core of what we're recommending is a reset. It's essentially saying that we have got to have a partnership between employers, individuals, and health services in order to tackle the issues that we're facing. And really what lies behind that is that obviously human health is complex, and so the issues that come up are many and varied. But most cases, health issues develop gradually over time, and then they can reach a point where they become acute. And at that point, obviously, people are not able to work and have to have absences from work or enter into various stages of treatment. But there's a truth, which is that the more you can prevent people from getting into that position, the better. And when you think about prevention in the context of health and work, employers have a unique role, really, in terms of prevention. I mean, if you take something like mental health, which has been a huge driver of the rising incidence of ill health across the population as a whole, particularly amongst young people, in many cases, not all, but in many cases, what starts off as sort of fairly low-level anxiety or some fairly early stage, even non-diagnosable, non-clinically diagnosable mental health conditions, those conditions can be managed. And actually, if they're dealt with well, and there's people that feel supported in the context in which they're working, they can not only not develop, but they can actually significantly improve, because these are very closely associated with issues such as sort of your personal self-esteem, the extent to which you feel valued, the extent to which you feel you belong. And all of those things are aspects that can be addressed and developed by employers in the workplace. And the difference that they can make, therefore, at that very early stages of prevention are huge. But it's also true for other ill health conditions. I mean, let's just imagine somebody who's perhaps in their 50s who has developed some kind of osteoarthritis or some kind of musculoskeletal problem. They will be obviously understandably concerned about their health issue. And probably they'll be thinking first and foremost about the importance of getting that to improve. If they work in an employer who is essentially supportive of them going through that journey, then they're much more likely to stay and work. On the other hand, if they're not in a supportive environment, or they don't have the opportunity to make some sensible adjustments and have some flexibility, they're much more likely to conclude that they're not really able to work anymore. And I think as individuals, as human beings, obviously the health issue is happening to us individually, but it's within the context of a workplace. And it is almost always, not always, but almost always better that we try to keep people healthy in work or keep them working while they're recovering and support them through that rather than having them leave work. Because as soon as you become detached from work and you become detached from their purpose and the sense of fulfillment that you can get from work, there's pretty clear evidence to show that many health conditions can then deteriorate from there, and you get comorbidities building up. So this is this whole issue about prevention and keeping people engaged in work is very important, both to them in terms of their development of their health conditions and hopefully the resolution of those, but also it's very much in the interest of employers.
And this takes us, Charlie, to some of the kind of other big concepts in the report in terms of the strategies that employers need to take in relation to how they best manage this issue, because we've been talking primarily about the effect on the individual, but of course the effect on the employer of people taking time off work because they're sick, or people who they've invested in who are experienced and skilled dropping out, that has a big impact on the employer as well. So share with us the kind of concepts you have around how it is how employers need to think about the kind of strategies they need to adopt here, and also about how government needs to support and work with employers to develop a different kind of mindset here.
So I think the first thing I would say is that it's important, I think, before we talk about sort of where we need to go, I think it's important to talk a little bit about where we are today. And so in the course of the review, we found a number of things coming up consistently. And the first is that there's a huge amount of fear that surrounds this whole arena. So if you're somebody who has a health condition, quite often you will be fearful of disclosing that to your employer. Because you worry about being judged, you worry about potential discrimination, you just have and I think it's a fairly natural and understandable thing to feel that way. But the important point to point out is that fear is also felt by the employer. So a line manager dealing with a health condition amongst one of their team is very often fearful about actually talking to that person about it. I mean, I've spoken to so many people who have said, they were off work for months and they never had a call from their line manager. And on the whole, that is not, I think, because the line manager is an uncaring person. It's because they're afraid of stepping into something which they feel is a personal space for an individual. They don't want to cause offence. They certainly don't want to give rise to any kind of complaint, let alone a grievance or a tribunal. But the significance of this issue of fear is that it creates distance between people, just at the point when you really need them to be talking to one another. And so, what we have is the situation we have at the minute is one where when people get ill, more often than not, they don't talk to each other rather than do. And of course, that means that the opportunity for resolution, the opportunity for flexibility, the opportunity to make sensible adjustments is often lost and can become adversarial very early on in the process, which just exacerbates all those issues. The second big thing that we found is that the level of support that's available to individuals and to employers in the workplace, and particularly line managers, is highly, highly varied. You have some employers that have really extremely good systems and support, and they achieve really very good outcomes with very high returns on investment and return to work rates. But you have others where there's very little. And then on top of that, we have a system with the fit note system, where we, quite understandably, the lead primary care provider for an individual is their GP. And so when somebody gets ill, they will go to see their GP. And what is happening in that situation is the GP is being asked to do two things. They're being asked, firstly, to diagnose the health condition of the patient in front of them and to suggest what they need to do to improve that and get better. But the second point they were being asked to do with the fit note specifically is to assess the extent to which that individual can work while they are ill or while they're in recovery. And what GPs have told us consistently is that they can do the first, that's absolutely their role, but they can't do the second. And as a consequence, what you see is, there's lots of stats around, but 93% of fit notes say that people are not fit for work. And one of the effects of this is the fit note can act as a bit of a firewall between the employer and the employee. So if you have this issue of fear, which is already creating a degree of separation, the addition of a fit note that says you cannot work simply exacerbates that separation. And it makes it very difficult for there to be a dialogue between the different parties that are required to resolve this issue. So this is what we've ended up in the situation we're in, where we're not talking about health issues as early as we should do with the people who need to talk about them. When people then do something about them, more often than not, it creates more separation rather than connection between the employer and the employee. And then we have a highly varied level of support that can then help people to find resolutions and get back into work and to recover well. So what we are essentially saying is that we've got to change that. We need to rehumanize the workplace. We need to make it a bit less procedural, less about risk management and more about dealing with people. What we need to do for that is we need to have employers recognizing that they've got this really very significant opportunity to play in the prevention space by creating the right environment, first of all, for people to feel safe to share and to talk about issues, but also providing support that's readily available for both individuals and line managers. So in the moments when something happens, people have someone to turn to who can help them to figure out what they can practically do about it. We perhaps haven't got time to go into all the detail, but we've spent quite a lot of time looking at what the nature of that could be. We've also found many examples of where that's already happening. And so in essence, what we're saying in the report is we need employers on the pitch. We need them playing across the full life cycle of employment and being more engaged in health issues. We need to improve the level of support that's available that supports individuals and employers. And critically, we need to also improve the level of data and the evidence base around what works. Because the other key factor we found throughout the review is there isn't very good data. And of course, the problem with that is issues become intractable without visibility and insight. Conversely, if we can change that, we think we can make them very addressable indeed.
And this, what you're advocating, this new approach to the kind of healthy workplace, to rehumanizing work, as you put it, which is a phrase I love, by the way. You've done really great work, Charlie, in identifying a whole number of employers who want to take this forward. You call them the vanguards. A number of NHS organisations amongst those vanguards. So tell me a little bit about what you're hoping from. What have they committed to? And I'm particularly interested in the kind of response you've had from the NHS, which of course is the single biggest employer in the country.
No, absolutely. Well, I think first of all, I mean, one of the things that we shouldn't walk past is the simple fact that we've had so many employers stepping forward to say they want to be a part of this is in itself, I think, a really significant and important point. I think what it signals pretty clearly is that employers recognize this is a problem which needs to be addressed, and they want to play a part in figuring out how to do that. And so we've been enormously encouraged by the reception we've had. I mean, I could almost say that we've almost not had a single employer say they're not interested in this. And I think what will inevitably be, some people will say, oh, is this just employers being asked to do yet more because they've already got lots of burdens and they've seen taxes rising and all this kind of thing. But my response to that is actually employers are already feeling burdened by this. They're already seeing it. I've yet to meet an employer who's not worried about mental health amongst their workforce, and they're finding it difficult to deal with. So the opportunity to then work with us to figure out how do we come up with practical evidence-based solutions that help everybody to manage these things better is something that a lot of the people have jumped at, which is terrific. And as you said, we've had a great response from a lot of employers, including NHS trusts and indeed the NHS organisation as a whole. So that's been terrific. What we're asking of those employers is essentially to say, look, what we want you to do in the first instance is embrace the fact that you have a big role to play in health, particularly around prevention and rehabilitation. We've it's pretty straightforward, but we've conjured this notion of this life cycle that people they get recruited, they get onboarded, they hopefully have a long period where they're healthy in work. They have sometimes when they get ill and they're in work, but they've got some kind of health condition. They may then have a period of time when they're absent from work because of a health condition. They hopefully return from that. And then at the end of that life cycle, they may find themselves in a position where they can't return to the work they were doing. And then we need to find a more constructive, better alternative. And the point we're making to employers is that you play across the whole of that spectrum, and we want you to think and engage across that spectrum. That's the first thing we're asking them to do. very importantly, what we've decided not to do is to take a very prescriptive approach where we sort of take each step of that life cycle and then come up with 15 things that each employer should be doing in every area. For the simple reason that that just becomes unworkable. And actually for a lot of employers, they just look at it and think, well, this is just clearly not for me. So instead, what we're advocating is that we want people to embrace the life cycle and measure some key outcomes. And those outcomes are absence rates, return to work rates, and participation by disabled people in work. And the reason we've chosen just 3 is because, again, we think simplicity is a virtue. And also because if an employer is measuring those things and trying to get better, they will very probably be doing some, or if not all, of the right things in their context. And so it's better that we sort of focus on the concept and the outcomes, and we leave the practices a bit more to those employers in the first instance. The second thing we're then saying is, but within that life cycle, we think there are some changes that we want you to embrace. And the first of those is really the counter to the point I made previously about people being off work and becoming disengaged from work. It's not okay to be off work and not in touch with your workplace. It's not generally helpful to anybody in terms of getting to the outcomes. So what we're essentially saying is we want you to develop the notion of return to work plans. And what we mean by that is sometime between 2 weeks and 6 weeks of absence, there should be a meeting between the employer, the employee, and a workplace health professional, workplace health provision person, to come up with a plan which says, right, so you're off sick, you've got this issue, we're going to develop a plan for how you can return to work, which could include flexibility, could include phased returns, whatever it may be. So we think that's an important addition in that landscape. And then the other point, which we feel is really key, is we want employers to embrace the concept of a stay-in-work plan, because the point I've been making all along about prevention is that the earlier you can get people to flag that they've got some issue, the earlier you can start to engage with it. And hopefully, in many instances, you can actually prevent people from needing to leave work at all, just by having a dialogue around it. And so we think the idea of a stay-in-work plan is also a helpful concept that we want these vanguards to explore. And of course, in order to get that to happen, you've got to think about some of the human aspects of the workplace. You've got to create an environment where people feel safe enough to say something earlier than they are today, perhaps. You've also got to have the mechanisms in place to support the line manager to do something, to be able to do something practical about that when it happens. And so we're advocating again for people to sort of disclose early, develop a stay-in-work plan, which includes adjustments and the like, supported by a workplace health professional in order to get to that, all as part of improving that landscape. But we've deliberately kept this fairly sort of high level at this stage, because the idea of the approach is that we're very clear. We need to move to a position where we change fundamentally the way that health is handled in the workplace. But we can only get there by working with employers. And therefore, by taking this approach and working with the vanguard employers, what we're going to be doing is doing deep dives with different employers to figure out what specific practices work best and generate the best results across this landscape, so that we can then codify those. We can actually, we can then reach a position in about 2 to 3 years' time where we can then define a standard for what workplace health should look like, that we can then encourage adoption for. And at this point, this is where the government then starts to play a key role around how they incentivize and assure the outcomes. And that's what we want to do with those vanguards.
Yes, and I absolutely sign up to your kind of model of change, Charlie, which is let's start with kind of voluntary action in order to kind of start to build the kind of muscles of confidence amongst employers and government, get the data, and then think about, okay, how can we think a bit more concretely about the incentives that would be needed to bring those who may not be leaning into this to it. We're kind of running out of time, but I've just got 2 or 3 final questions for you, Charlie. One is there's an intriguing reference in your report to kind of around health and work being part of the neighbourhood health offer that the NHS makes. Now, absolutely agree with this. It is very clear to me, to us in the Confederation, that part of the challenge for the health service is that we medicalize problems which are actually primarily not medical problems. And one of those ones is indeed around employment, about people dropping out of work, about people feeling they can't get work. And there are pockets of good practice. There's a place I visited recently where a job centre plus has somebody who does sessions at the local primary care centre, so that the GP can refer, or other members of the primary care team can refer that person to a member of staff from Job Centre Plus to talk about how it is they can get re-engaged in the labour market. So there's something here, isn't there, about a more holistic offer for those people whose challenges span the health and employment experience.
There definitely is, and I think that the first thing in terms of the reference to neighbourhood health is something that I really welcome within the NHS 10-year plan is the recognition within that work is generally positive for health. So, and I think this is an important sort of it might seem like a fairly high level shift, but it's an important one because one, there's a lot of evidence to suggest that is true. But secondly, I think it creates, I hope, a sort of direction within the NHS to look to encourage outcomes whereby continuing work is part of the therapeutic journey to getting better, rather than it being separate, which is, I think, the situation we face at the minute. But I think the other thing to say is that one of the things that we're very keen to do as part of the work we're doing within the Vanguards is work with some of the pilots that you've described, whereby you've got some GP surgeries with work coaches and other support services in there. The Work Well pilots, for example, have got many, I think, quite positive aspects. And what we want to do as part of the work we're going to be doing over the next few years is work with those pilots to figure out how do we actually leverage some of those resources and those capabilities that have been put in there so that it can help us to get to a better outcome. Because I think on the one hand, it's a good thing that we're saying that work is good for health. But what we also have to do is think about how do we support the health system to generate outcomes which reflect that. And we won't get there without putting in place some of the resource and some of the practices that we're advocating for in the report.
Now, Charlie, you're in the process of promoting your report. I'm sure a government is going to be very supportive of your work. So probably this isn't a time to be critical of government. But nevertheless, as someone who I will have a future role chairing a work-related agency, the Fair Work Agency. One of the things I've been saying to ministers is how can we join up better across government in relation to work? Because you and I have looked at this from the kind of productivity angle when we were thinking about industrial strategy. You're looking at this now from the kind of angle of worklessness, employability. I'll be looking at it from the kind of context of compliance and enforcement. It feels as though it's hard to join this up. We've worked really hard in the Confed, and we've actually got somebody here, as you know, who's been on secondment from DWP working with us on work and health. And I remember when I first approached DWP and said, look, a lot of our members would like to do work in this health and workspace. They were delighted because it's really actually not very easy in Whitehall to lean out from your department into other departments. So without being critical of government, it would be good, wouldn't it, if there was a bit more kind of joining up around a kind of cross-governmental strategy in relation to work?
I think that's basically true. And I think my sense in the government from the conversations I have is there's a real recognition and openness to doing that. I also would just go back to what you mentioned before about the way you drive change. I mean, the reality is that the territory we're talking about, whether it's what you're talking about sort of the workplace and good work, etc., and what I've been focusing on here, which is about health in work, it is complicated, and it'd be nice if it was simple and you could come with some very simple solutions to it, but it isn't. And so the only way to actually drive change here is to create a process for change and a momentum and bring with you a lot of supporters and a lot of people engaging in that, and then work on it and gather data and gather evidence and create groupings of people who really do then get into the detail of how do you join up all these different aspects. And one thing I'm excited about in the next phase of the review is we've got the opportunity to do exactly that. And I think one of the things that I did when I first took on responsibility for leading this review is I read a lot of the previous reviews that have been done in this area. And I'm pleased to say that actually, if you look at some of the things that Carol Black has said and Paul Farmer and Dennis Stevenson, there's a lot of read across between what they have said previously and what we're saying today. And what we've tried to do is sort of say, well, so quite a lot of the challenge is therefore not so much about what you have to do, it is about how you do it. And so a big part of what we're saying in our report is let's look at how do we create the momentum for change and how do we build the engagement and the participation opportunities in change such that we can actually make this happen. Because if we don't, we're going to lose a lot as a country. If we do, frankly, everybody can win from this. And it feels doable, but we need to be persistent and we need to, to be participative in terms of how we go about driving it. And I think there's an opportunity, frankly, to work closely with a lot of other areas. I think some of the areas around that you're going to be covering will have a read across into the territory that we're talking about.
Well, Charlie, that's great. You've kind of preempted my final question, which was, the point about these reviews, as you and I both know, and in a way, the fact that you've referred to other reviews that have said similar things makes this point, is it's not about getting to the date of publication and then feeling the job is done. The real work is the work that is done after publication, which is quite challenging often because some of the kind of infrastructure of support you've had in the process of producing the report isn't there, but it's actually about building a movement. And I'm delighted that you're going to be joining the Confed's Work and Health Network in a few days' time. We had the first meeting of that network, Charlie, a couple of weeks ago, and there were 250 people there from trusts, from systems, from local government, from the third sector. Real momentum. So I do hope that you'll work with us and with our Work and Health Network as we build momentum behind the really important ideas in your report. Charlie, thank you so much for joining us on Health on the Line. I'm afraid that's all we've got time for in this edition of Health on the Line. We'll be back with our next episode in a couple of weeks. But in the meantime, please do follow us and leave us a rating or review wherever you get your podcasts. And if you have an exciting or innovative program of work that you want to tell us about, talk about on Health on the Line, well, do please contact us. You can do that through healthcomsplus@nhsconfed.org. Thanks for listening and goodbye.
You've been listening to Health on the Line, produced by Health Comms Plus. Health Comms Plus is a highly effective, innovative and creative communications agency brought to you by the NHS Confederation. We offer a creative, professional and cost-effective service for NHS and public sector organisations across the UK. Any profit we make is reinvested in the support we provide to NHS organisations and wider health and care systems.